Today I'm going to talk to you about insulin pumps, hybrid closed loop systems, and automated insulin delivery, or AID. I'd like to acknowledge with gratitude that this presentation was created on the unceded homelands of the Musqueam, Squamish, and Tsleil-Waututh First Nations, and to thank them for their stewardship of these beautiful lands over all of these years. So what's an insulin pump? And I'm sure many of you have a good idea about this, but it's basically a small battery-operated mini computer. The insulin's delivered subcutaneously under the skin, continuously through a small, soft, medical-grade Teflon cannula, which is what is allowing the insulin to get into the subcutaneous tissue. So it can be have tubing, or it can be tubeless. Each pump has a reservoir which holds insulin for delivery. So each pump has a different volume of reservoir. Most are about 300 units of insulin that it can take. And the whole system should be changed every 2 to 3 days. And there is one device with Medtronic that allows the tubing to be changed every 7 days, but typically it's every 2 to 3 days. The delivery of the insulin is programmed by the diabetes team, the endocrinologist, certified diabetes educator, the RN, and the RD within those teams. So insulin pumps are often called CSII pumps, which is continuous subcutaneous insulin infusion. So as you know, you sometimes are working with insulin infusions, and that's through the vein. So a little different location that the insulin is being infused through. This is through the subcutaneous tissue. So from now on, we'll call it a pump or a CSII pump. So how does it work? It's supposed to imitate the normal function of the pancreas. So in the normal function of the pancreas, when we eat and our glucose level starts to rise, we have insulin which is released into the bloodstream, and it will carry the glucose through the cell membrane, through the interstitial fluid, and into the actual cell itself. So it only uses rapid-acting insulin. There is no long-acting insulin, mixed insulin, or intermediate. Our normal pancreas puts out insulin that will act immediately for us. And it delivers insulin in 2 ways by this pump. In a normal functioning pancreas, we don't need a basal rate and a bolus rate because it works properly and it will respond to the demands immediately. So there's no need to schedule any rates in it. Our body does it normally. But in a pump, we need to regulate how much insulin is going in so that they don't get left without any insulin on board, which is dangerous because we all need insulin in order to fuel our cells with the glucose. So the basal rate would be just a small amount of insulin delivered continuously for 24 hours. So it can be programmed to deliver different basal rates for each 24-hour period. For example, between midnight and 3 a.m., they might get 0.5 units of insulin an hour. And then they need more because of dawn phenomenon or Somogyi effect there. And at 3 to 6 a.m., they may need 0.75 units an hour. And so that's what traditionally an insulin pump has done, but we have newer versions here which don't require us to actually program a basal rate anymore because people's needs change every day and even within that day. It's not this, they don't actually require the same amount of insulin every day at the same time. So the adjustments are made on individual needs and they're fine-tuned. The bolus rate is just that. So if the glucose levels are rising due to a meal that they've eaten, or if it's hormonal changes or stress, they can add and make a decision on how much bolus they're going to give. So that they can manually enter a bolus using these calculators that they have determined with their diabetes team, and that is based on how much carbohydrate they're eating and whether they want to lower their glucose levels with a correction factor. So if they're running high and they're eating, they may want to give this amount of insulin for the meal, but knowing it will only cover the meal and not the fact that the glucose is high and it needs to come down quickly, the correction factor will be added to that. And sometimes it's called an insulin sensitivity factor or correction factor. And this prevents the stacking of insulin, as we know is dangerous because they can have rebound hypoglycemia. So the overall premise is it's meant to mimic the normal pancreas, uses only rapid-acting insulin, either Humalog, NovoRapid, Apidra, Admelog, TruRapi, all of those rapid-acting. So how does it work? In a normal functioning pancreas, if someone eats 3 meals a day, you're going to see a glucose rise 3 times a day. And you're going to want to see a corresponding insulin rise in order to keep the glucose levels within target level, which is usually between 4 and 8 or maximum 10. So the reason that the insulin has to go up quickly with the meal is that it's to keep the glucose levels within target. So this is an example of A, how much the glucose needs are, and B, how much insulin is required to bring those glucose or keep the glucose levels in normal target. You'll notice as well that the insulin level never goes down to 0, and that's because the liver and muscles, adipose tissue, and kidneys are constantly putting out glucose in between meals and overnight to keep our vital organs running. So with insulin pens, we try to mimic this, right? We're trying to give a rapid-acting insulin 3 times a day matched with the meal, and a long-acting insulin to try to imitate what that normal pancreas will do. And so the insulin pump will do that with only rapid-acting insulin, and it will be a little bit more manageable for the person if they decide to stretch their meal out and not eat, fast for longer periods, or they have inconsistent eating. It's very helpful for them to be able to just give their bolus with the pump that is on them at the time. So an insulin pump is comprised of several parts. One is an infusion set. We have to make sure that the cannula goes under the skin into the subcutaneous tissue, that a tubing is going to deliver the insulin from the actual brains, which is the pump itself, into the subcutaneous tissue. Now that's the tubed pumps. We now have pumps without tubing, which I'm going to review a little later. So the premise behind closed loop or hybrid closed loop systems is that the person doesn't have to think as much. So what that is made of is a glucose a continuous glucose monitor like Dexcom or Libre, or if they're wearing a Medtronic pump, it could be the Medtronic Guardian, and it will read the result, measure it and read it to the pump, and it does a very fancy algorithm calculation and determines how much that person is going to need based on what their history has been and what they require. So it's almost like an AI continually thinking and learning from the person that their needs have changed and that they need to adjust how much they're delivering. And then it will deliver that insulin dose to the patient, and it's this continuous loop of measuring the glucose every 5 minutes and delivering the amount of insulin that a person needs. The person still does need to tell the pump that they're going to eat, though. We don't have ones that smart yet. So they still have to indicate that they're eating and insert their, it'll do a calculation for them, and then they can choose to accept it or not. But what I want to remind you as well with the CGMs, or continuous glucose monitors like Dexcom, Libre, Guardian 3 or Guardian 4, that it is not the same measurement of glucose as it is for a capillary glucose. They're 2 different compartments. Capillary glucose is a lancet going directly into the capillary, the blood, and it is measuring the glucose that's in the blood vessel. Interstitial glucose, which is what CGMs are monitoring, wait for the glucose to get out of the bloodstream and into the fluid, the interstitial fluid, around the cell before it will measure that amount. So if the glucose levels are changing very quickly, then there is sometimes a delay or a lag time between that glucose reaching the interstitial fluid, and that's why sometimes you won't see a perfect match between a blood glucose level and an interstitial glucose level. So the types of insulin pumps available in Canada are Medtronic, Ipsomed and Tandem, those are the ones with tubing. And the one that's available without tubing is Omnipod. And that's the one that you wear on your arm or your belly. And it contains the insulin within that pod. And then it has a personal data manager, which is a device like a cell phone type thing that will tell the pump what to do. And they can make all of their adjustments with this separate device. So infusion sets is where the insulin is going to actually go in the subcutaneous tissue. And there's a fine cannula that's inserted with a needle, but then the needle's removed, so they only have a flexible cannula left under the skin, which means they can move comfortably around. The infusion set is worn for 2 to 3 days before it's required to be changed. I mentioned before, Medtronic has a 7-day infusion set now. And Omnipod has the cannula attached directly to the pod, which contains the insulin, so there's no tubing required there. So this is what we used to have to do. And I mentioned before, so if between midnight and 3 a.m. the rate is 0.5 units an hour, but then they realize they need more insulin continually coming out every hour, or every 5 minutes actually is when it delivers it typically, they will change the rate according to what their glucose levels needs. And you'll notice this person under basal rates on the left side of the screen here is that at 8 o'clock they need much more insulin than they did overnight, 1.15 units an hour. And then at 3 o'clock they need a little bit less, 0.75 units. So traditionally it was this set amount that we were giving every day, but we know that people use have different needs every day. So sometimes this wasn't the best match. And that's why hybrid closed loop systems have got such a great brain on them, and they will adjust accordingly. They also will back off on the amount of insulin if the sugars are starting to read that they're going low, and it will actually turn off the pump and not deliver any insulin until the glucose level rises over a certain amount. Or if the glucose level is starting to drift high, it can kick in extra insulin. It's still not perfectly accommodating the meal, but it is covering a little bit of the meal when it senses if someone didn't give their bolus insulin prior to their meal and the glucose level rises, it actually will kick out a little extra insulin, but not usually enough to cover the meal. And then here'd be an example of an insulin sensitivity factor or correction factor, and it means that for every 1 unit of insulin I give, it's going to drop the glucose by about 4 millimoles. So if I need to drop my glucose by 12 millimoles because I'm running that high, I'm going to give 3 extra units on top of what I would give. And then the active insulin time is typically 3 to 4 hours is how long that insulin will take to absorb. And then you can see that the target ranges are written in here. So this is for a static pump that isn't reading back from the CGM to the pump and taking over operation of the pump. This is what we actually get as reports. I'm not expecting anybody to memorize this, but I do want to point out the pink in the bottom is the amount of insulin that's being put out in that little sliver of time. So you'll notice here that the blood sugar starts to drop very quickly here where my arrow is. And you can see that the pump actually turned off. And in the pink, there's nothing being given here. And it's starting to, it drifts low for quite a little bit. So it's not giving any insulin until it senses it going back up again. So it's very safe to give, and it's taking a lot of the guesswork out for people with diabetes. So what are the benefits of an insulin pump? There's precise dosing. You can't give 0.25 units of insulin in a syringe or in an insulin pen. But these can give very minute amounts, sometimes up to 0.025 units difference, increments. It's more flexibility because they've got everything with them. They don't have to carry a pen, they don't have to inject a needle, they just pick up their pump or their reader, and they can very discreetly give what they need to give. It's more predictable in its absorption because you're not going from site to site. For 2 to 3 days, you're infusing in the same site. And that's why it needs to be changed every 2 to 3 days, because infusing too much insulin in one site can cause some lipohypertrophy or very hard lumps that it won't absorb well. But you have less chance of lipohypertrophy with the insulin pump because you're not injecting 4 times a day with a needle. You're going into the one site very consistently for the 2 to 3 days and then changing to another site. So there's less incidence of that. They have improved control. There are data to show that glucose control is much better, and obviously less or no manual injections. But what are some of the challenges? So there is a risk of DKA. You're giving rapid-acting insulin. If something happens where that insulin is not infusing, let's say the inner cannula kinks, or the site is compromised, or there's a kink in the tubing, anywhere where the insulin is not being delivered, you're only giving rapid, and there is no long-acting insulin to cushion them through. So they could go into DKA quite quickly. They could have an infection at the infusion site, as is the case when you always when you have something under the skin. They can have hypoglycemia as well if it infuses too much at a time that they don't need it, and that's less for the newer versions than more for the older versions. Body image, they don't want to carry something around or have this stick out. There's a steep learning curve. They do need to really be on board with wanting to understand how the pump works, and it's not something you can just put on and walk away. You need to understand it and how to care for it. And the average pump costs for the actual physical pump, apart from Omnipod, which is a monthly fee, the costs are about $7,000 for the pump and about $300 to $500 a month for supplies. But there are some coverage available through BC Pharmacare, through private care, so they may be only paying nominal amounts like $50 a month out of pocket. So when should an insulin pump not be used if they're admitted to hospital? Well, if they're admitted with DKA, there's a reason why they came in with their pump and they're in DKA. So there's something blocking it, preventing the insulin from going in, or they weren't able to self-manage it at home well and react well. If they're admitted to critical care, we've used a blanket statement just to say that they're probably not in the best shape to manage their own pump because they do need to manage it themselves. The nurses are not expected to understand or be able to navigate through that pump. So we've just made a statement to say to remove it if they're in critical care. And they often have either insulin infusions going or subcutaneous replacement. If they're in an altered state of consciousness or any cognitive impairment, whether that's short or long term, then we need to get an assessment and see if they are appropriate for self-managing. If they're receiving medication that means that they can't operate that pump well, then we would need to discontinue use of the pump. And if they have altered visual acuity, they can't see or they can't manually touch the buttons that need to be chosen in order to deliver the doses, then they wouldn't be contraindicated for use. If they're at risk for self-harm, insulin, as you know, can be life-threatening and used as a weapon to act on self-harm. If the pump is not working properly, as evidenced by the alarms going off or rising glucose that they can't control, it should come off. Or if they don't have enough supplies for the pump, there isn't a diabetes clinic that is going to have the specific particular supplies that are needed. So if that person hasn't brought their supplies or cannot get them brought to the hospital, the pump would come off and they'd revert to sub-Q or IV infusion. So what do we do at point of care when the patient has an insulin pump? So the inclusion use is, it's appropriate if they are alert and oriented and they can manage that pump themselves and the physician or prescriber has authorized that they can continue to use. If they have the physical dexterity or vision to operate the pump, they can provide all their own supplies, although the pharmacy can supply typically the insulin that is in it, apart from some of the more rare ones like Fiasp, which is not available on a hospital formulary, and obviously making their own adjustments to the doses. Even if there's no access to a prescriber or a certified diabetes educator, they came in with that pump, they were managing it well at home. If they can continue to use that in hospital, it should be encouraged. So what's the nurse responsibilities? Well, we still need to know what their sugars are. So either a patient has a blood glucose meter that's compatible with their own pump, and some pumps require a specific blood glucose meter, so they couldn't use yours, but the patient would test their own glucose using their own meter and then tell you what that glucose reading is. They could be wearing their real-time continuous glucose monitor, Dexcom, Medtronic, Libre. Intermittent scan, continuous glucose monitor. We still have a few, one of those around, the Libre 2, but probably isn't going to be in circulation for many more years as they've gone to the Libre 3. And if the patient does not have supplies, of course, they have to revert to a hospital meter, and you need to communicate. That's the key. If they're using their own blood sugar meter, then there certainly is the option to send a venous blood glucose to compare, and really a point of care blood glucose meter has the same variance as either a home blood glucose meter or a CGM. They all have about 10% off the lab. So if you're comparing a meter to a meter, hospital meter to home meter, there could be a variance either way of up to 10%. And it really should be a venous that it's compared to, because we know that's the most accurate glucose reading. And then discussion, back and forth, communication, and documenting that in the electronic medical record as to what their glucose levels are, because it is important that you know what's happening still with their glucose levels. If the patient has 2 consecutive glucose readings that are greater than 14, then the Diabetes Canada recommends, if they're within 4 hours of each other, get an order from the prescriber to send blood ketones for stat analysis, and that's especially important in type 1 diabetes. And the nurse can help remove the infusion set if the pump is to be discontinued, but they're not responsible for reinserting it. Removing the infusion set is just like removing any other butterfly or anything else that we use in the hospital. So it's really best if we allow the person to use them, their own devices there, because they do a better job of managing their glucose levels than we do guessing. So this is the Omnipod pump. All you would do is take your nail and peel up around all that tape around the edge and gently peel off the pod itself. There's a flexible filament under the skin. It's not a needle, so you can pull in any direction there. And removing these infusion sets, you can disconnect it at the base. And so here you see this person's pinched these 2 clips on the edge, pulled it and removed it from the actual infusion site. This is the tubing, and they've disconnected it. So if they needed to go for a test with this type of pump, that needed to be removed, they could disconnect this, put this in a nice clean 4x4. In the meantime, the pump stays outside of the MRI machine, and when they finish their test, they can reconnect it and resume their pump. So what's the patient responsibilities? They need to tell you what the glucose, communicate. It is important that you still have some awareness of what their glucose levels are. They need to provide their own supplies. They need to document, or we need to document the amount of bolus only. So they need to tell us, I've given 4.25 units for my breakfast today. And then you can insert that in the EMR or wherever you're documenting. And then the patient manages their own pump and infusion sets. You are not responsible for doing this. So the patient or nurse can assist removing the infusion set for whether there are issues with the pump, or they're going into DKA, or perhaps they're going for a test that requires it to be removed. And this is an overview of the medical imaging test list that Providence Healthcare in Vancouver has. I will say that there are some data to show that MRI and CT actually don't require removal of the site itself, and that they might be able to wear a pump, like a CGM for sure, but certain pumps are going to need to be removed. So we rely on the medical imaging team to tell us whether they need to be removed or not. So the key messages are that insulin pumps are a really valuable method of maintaining target glucose levels in people with all types of diabetes. They are most closely imitate what the normal functioning pancreas should do. So they are gold standard. They need to be maintained and managed by the person with diabetes while in hospital. They are not the responsibility of the nurse to adjust the doses, change infusion sites, or troubleshoot through, but they can be removed by the nurse if the patient's unable to self-manage. Let's say they came in with a stroke and they don't have the dexterity to remove that. It's certainly within our scope of practice to be able to remove this. Thank you for your time.